presenter. So I'll introduce Cindy as the Director General of Health Programs and Strategic Initiatives at Health Canada. She is responsible for a number of program and policy areas, including sexual reproductive health, thalidomide, sex and gender-based analysis, brain health research, blood research, and organ donation and transplantation. She's leading the work of the Organ Donation and Transplantation Collaborative, a collaboration of provincial governments, clinicians, patients, and stakeholders in the sector. Cindy has held various positions at Health Canada and previously worked over 20 years in the not-for-profit sector in the areas of anti-poverty, homelessness, and international development. So without further ado, I'll hand it over to you, Cindy. So thank you. I look forward to hearing more from you.
Thanks so much, Craig, and congratulations on being a new dad. That's awesome.
Thank you.
So hello, everyone. I'm coming to you from the unceded territory of the Algonquin Anishinaabe in the Ottawa area, and very grateful to be here and very grateful for this opportunity. I was very, immersed in the previous presentation, so now I'm trying to turn my brain around to what I'm supposed to be saying. I might go a little bit off script here, but next slide, please. And I hope after the last couple of presentations, this is not too bureaucratic. So, you know, you're well aware of the challenges in the healthcare system. Organ donation and transplantation is, in my view, a poor cousin within the broader health system. Of all the issues going on, we have to fight for resources and attention. It's a very, very small and specialized sector. And for Indigenous peoples, of course, it's that much worse and that much harder. So we have huge challenges ahead of us. And I'm hoping today might be the beginning of more conversations to come in terms of opportunities to work together. Next slide, please. I've been working in the organ donation and transplantation area since about 2008 in a fairly limited way. Health Canada provides funding to Canadian Blood Services, who's responsible for public education, developing leading practices, and they also receive funding from provincial territorial governments. And so there was definitely a lot of collaboration between the federal and provincial territorial governments on what we expected from Canadian Blood Services, what Canadian Blood Services could deliver with the teeny tiny amounts of money that we were giving them. But there's way more to this work and way more to this sector. And, you know, Canada does okay compared to other countries, you know, and I'm generalizing across the board, you know, as we dig into outcomes for Indigenous people or racialized Canadians or others, then, you know, it looks grimmer and grimmer. But back in 2018, we just kind of realized like we're just going around in circles. You know, we keep kind of doing the same thing, and we're not getting a lot of traction or mileage for the level of effort. So we started with a consultation process. We reached out and we had fairly intense interviews with about 100 or so stakeholders. We did reach out to Indigenous organizations and individuals. There's a quote here from Indigenous Physicians of Canada, who we spoke with, and a few others. But it was pretty limited, I have to say. And then at that time, and sort of in the year or two after that, you know, we were really making cold calls to organizations or individuals kind of trying to make contact. And it just wasn't working for a variety of reasons. There was, you know, things on our side, there were capacity limitations, the you know, all of the attention around the, you know, you may think not enough attention, but there was this kind of this tsunami of demands on Indigenous organizations with the release of the Truth and Reconciliation report, and it's just impossible to keep up. So, you know, I think it was a little bit of a sort of a wrong place, a wrong time. And, you know, now like 5-6 years later, I'm really looking to course correct that. We're sort of at a new stage. It's a really, really good opportunity in terms of finding better ways to work together. But in 2018, we had the stakeholder report. We got a lot of really, really good feedback. We brought people together in a workshop back in the day when we had these big face-to-face meetings with hundreds of people in dark hotel rooms. That sounds really sordid, but you know what I mean. And we through that we developed. You can go to the next slide, Craig. Developed a number of recommendations and actions. And out of this, we formed what's known now as the Organ Donation and Transplantation Collaborative. So on the next slide, please. Oh, there we go. So the collaborative is intended to be time limited and transformative. I mean, Health Canada is not in the long-term business of delivering on organ donation and transplantation. But, you know, we have played a convener role to bring people together. It's, as I said, it's a small sector, but full of expertise and experience, and it's a sector that knows each other very well. So, you know, and organ donation, transplantation, as you know, is life and death. So while it's a poor cousin within the broader health system, it's vital for individuals who need a donation or want to donate or have family members or whatnot. I mean, you know, we don't have a lot of time to fool around. And so we formed this collaborative, which did a couple of things. It brought together sort of from the ground up a number of working groups that formed around key recommendations that came out of our initial consultations. We were able with, I'm just reading the chat about poor cousins. We were able to lay our hands on some funding for a limited time. So, you know, we were able to fund a couple of projects that we wouldn't have otherwise been able to, that again gave us traction. So the presumed consent that Carolyn just talked about, we funded some work to look at the evaluation of that presumed consent legislation and how to make that more available across Canada. And there are other jurisdictions, Quebec, and I think there's a third who's considering it, but I don't want to name names in case I'm wrong, that are looking at introducing something similar. Data, the lack of data is a huge challenge. It's a perennial challenge in healthcare systems, and it's a huge challenge in this space. So we have been providing funding and will be providing funding on an ongoing basis to organizations like the Canadian Institute of Health Information and Canada's Health Infoway to develop an interoperable system. So what we're doing is taking existing systems that provincial governments and hospitals are using, and how do we get them to talk to each other, and how do we have sort of a common understanding and common data across the country. Super oversimplification. But, you know, really trying to get at that. And the other issue, which is sort of my preoccupation today, is that there's no governance structure in Canada for organ donation and transplantation. I talked earlier about provincial and federal governments working together, but that was all focused on funding that goes to Canadian Blood Services. There's a provincial territorial group, but their mandate is to oversee funding to Canadian Blood Services. There's no organization in this country that has a mandate to oversee or guide or lead or drive change in the area of organ donation and transplantation. Don't get me wrong, there's a lot of collaboration. Provincial governments work with each other, organs cross boundaries all of the time. And this is stitched together through hundreds and hundreds and hundreds of MOUs between each province on each organ, different agreements on different kinds of things. But it's really held together with duct tape and on the basis of goodwill. So through the Organ Donation and Transplantation Collaborative, one of the things that we were able to do is to get the attention of federal, provincial, and territorial deputy ministers across the country, and we report into them on a formal basis. And we're now at the stage, 5 years later, where we're looking to wind down the collaborative and transition to a more permanent governance structure that would continue reporting to deputy ministers, so that it would have a line of sight into decision makers who hold the purse strings, who have a sense of the overall system and relative challenges, and that would be led by senior enough officials to be able to make some decisions. I think if those of you that have been around town long enough, you've probably seen a lot of federal, provincial, territorial committees come and go. I think what will be different about this one is that there will be a dedicated patient advisory committee, and there'll be a dedicated committee made up of clinicians and researchers and experts and administrators to provide advice as well. So it's going to be more organic and interactive. And then on the next slide, please. I think kind of where I want to finish is the challenge in terms of where we're at. So as I said in the beginning, we were not successful in undertaking any meaningful Indigenous stakeholder engagement. We have some engagement, like it's not nothing, but it's nowhere nearly close to enough. And then as we were developing the new Pan-Canadian governance structure, which, based on consensus and, lots of work went into it, we wanted to bring Indigenous perspectives and organizations into that. But, feeling very uncomfortable about, well, we've set up this governance model. What do you think? And do you want to be a part of it? And I don't, correct me if I'm wrong. I would love to hear from you and your views on this and over the long run as well. But we didn't feel that was the right way to go. So how we're positioning it is we have worked with Dr. Tate to develop, and with Indigenous Services Canada, to develop a policy statement on Indigenous engagement that is meant to be transition advice to the new governance body in terms of the work that they're going to have to take on. And, I would love to see Indigenous representation through all of the committees and working groups that are going to be part of the new governance structure, and possibly a standalone Indigenous working group, or maybe that's something that could be served through this think tank that Carolyn is talking about. There's a lot of room for discussion, but we really, really have unfinished business. And so while, we didn't get it right in the last number of years, we're at a critical point now in terms of launching a new structure. And I'd really like to better understand and sort of get some advice on how we can work together and what the path forward is that's going to serve your communities in your interests, and make sure that you got sort of a voice around the table. So I think I'm going to stop there, Craig. It's a lot of information for everybody to digest, and leave it for the discussion with me and the other speakers. Thank you.
Great. Thank you very much, Cindy. Great to hear all the work that you're doing there with Health Canada and collaborating with Dr. Tate and Indigenous Services Canada as well. So I was looking through our questions here as well, and I did have a couple that came up from Dr. Gill's presentation. So maybe I'll direct those to Jag first. So the first one I had on here was, Dr. Gill, how do you think this important work can be incorporated into the deceased donation realm?
Yeah, it's a very good question. I think I think there's a lot of the issues around deceased donation are going to apply the same principles, right? So you have to start with engagement. What Carolyn alluded to in terms of the presumed consent process that's unfolded, I think, is a good example of where if you don't have sufficient engagement, then issues come up after the fact. I think developing trust is huge in organ donation. And so I think making sure that we apply this process that's very similar to what we've done in organ donation, making sure that people aren't feeling compelled to donate, they're understanding what's involved. applying that same cultural safety and, arguably navigation support for families who are going through that will be important. I think in some ways it's easier to implement because it's, typically hospital based if you look at the actual act of consent and organ donation. But the broader work really needs to be done in community, right? To increase awareness about donation, what the process is, debunk some of the myths. So this work, I think, is going to have some spillover effect in terms of hopefully building trust and building some increased understanding about, kidney disease, about living donation, and I think by proxy, organ donation in general. So there is a whole area that we haven't embarked on in a major way yet, but is to partner with community to make sure we have a presence in community events, that there's opportunities for community awareness. And that's where I think we'll start to see the spillover into deceased donation as a start piece. But I think if we really want to get at the nitty gritty, that's like a whole separate piece we need to tackle.
Great, that's fantastic. I had another question for you here that popped up in the chat, so maybe I'll just ask that one to you as well. It says, Jag, great presentation. Thank you. Very refreshing to hear that your project focused on cultural safety and more so that Indigenous leaders and patients were the decision makers of this initiative in order to create an appropriate approach and objectives. Just wondering if you could speak a bit more on how you see this playing out in remote communities.
Yeah, that was kind of the main point. So the communities we kind of started thinking about that were, most impacted were remote communities. And so a lot of the components, so for example, the idea that we need education that can be virtually provided and not all in person was based on the fact that that needs to be accessible to remote communities. I didn't mention it in the talk, but when we're talking about this virtual navigator option, we recognize that not every community has appropriate internet access. And so we're also looking at creating digital kind of, whether it's a DVD or some sort of a system that can be used in communities where they don't have great internet access, but the material and the tool could still be used, like an app or something. So that's one way. In terms of the navigation piece of it, a major component of the navigation, is going to be working with patients in remote communities to kind of understand that whole travel burden piece. And I think understanding, we've got algorithms laid out. I didn't want to get into the details, but basically where you say, okay, where do you live? How far?
Gold code, it's very cool. So just a second.
Oops, sorry, someone just needs to mute. So it was, I think the idea that working with different communities to understand kind of like how quickly can someone get a workup? How long does it take to get that heart test done? And can we streamline it or pay for someone to just come down here and do it when we see them? So I think that will be a huge benefit for remote communities, and a lot of the navigation pieces focused around that.
That's really great. Yeah, I know it's really important to connect with those rural and remote communities.
Yeah, it's challenging, right, Quick, because if you think about it, like one thing that's interesting is that there's not a lot of communication between the Indigenous support systems in the different health authorities, which is interesting, right? So you could be in one area of the province and the other province, and you have Indigenous health teams working there, but they don't talk to each other very much. And so that's one thing that at least through this project we're starting to do is to get that communication happening. So I'm hoping that's going to branch out to help out in community a bit better as well.
Awesome. That's great to hear. I see Grand Chief Philip has his hand up, so if you wanted to unmute and ask your question.
Yes, thank you. I've enjoyed the presentations and again find them informative. One of the questions I wanted to ask Dr. Gill is which manifested itself in the David Dennis case. It's the matter of standards that the transplant has in terms of sobriety. And, that's what the issue was. it wasn't an issue of color or anything like that. It was the fact that tragically David couldn't maintain sobriety for the period of time necessary to allow for the transplant procedure. And I'm on the board of directors of the Round Lake Treatment Center, and we have the same issue with, I received so many phone calls of people I know who desperately want to get into treatment. And we have a waiting period. And that's has been established over the space of time in regard to ensuring at entry the patient has the best chance of completing the program and coming out the door, with the full measure of sobriety. There's a gap there. And I talked earlier about sobering centers. We have, I can't remember the proper term, detox. And I think those areas are neglected to the point where, unfortunately, like David is attempting to get a transplant, but he's not fully prepared. And, I think that needs to be taken into the mix. My final comment is, I really support the work that's being done here to raise the profile, but at some point in time, we need legislation. And, it may seem like a distant light in the darkness, but I think we have to, as I said earlier, add some light to this matter. Again, thank everyone for their presentations.
Thank you, Grand Chief Philip. I think those points are completely accurate. So I want to address the first piece around sobriety. That has been a major challenge, and so with the David Dennis case and kind of what's happened since then, I had put in the chat earlier. There is a problem in healthcare when we have arbitrary timelines on certain things. I think where we just say, 6 months is a made up number. It's not, there's not a lot of evidence that supports that actually. And so the amendment that's come, there was a white paper that was produced by the Canadian Society of Transplant, which has an ethical group, like an ethics committee. And they put together recommendations saying that you should not have absolute cutoffs. And because I think what was happening at one point was people weren't even being referred if they were not meeting those 6-month timelines. And so you're not even getting a chance to assess somebody on a case-by-case basis to say, what are the circumstances? How are we defining sobriety? Is it someone who's been clean for 2 years and then they had one drink, or is it somebody who's actually been consistent? So I think we need to get away from those blanket yes, no, black and white kind of scenarios. I think it's much grayer than that. And so the way we implement that needs to be case by case. And that's part of the rationale when we thought about that whole opt-out referral system. Is the notion is we really should be seeing everybody, every single person who could potentially get a transplant. And I know there's issues around people saying wanting to streamline healthcare and triaging, but I think this is a scenario where that's actually harmful and we shouldn't over triage. We should actually see everybody to understand these nuances. It's really difficult in terms of getting access to care because, again, the other thing we do and is to say, we need sobriety, but then there's no supports in place to actually make that happen. And so I think partnering with some of those organizations you mentioned would be very wise to say, because this is a time-sensitive issue, we need to get a space there. Is there ways to get that done? If it's holding up some someone's transplant, then we should do that. The other area that's similar to that is mental health, where people who have active mental health issues that often goes along with substance use, they need to be tackled. And it's the same problem. It's an 18-month wait list to get mental health supports if you can get any in our province. And so I think, when you talk about legislation and approaches, I think it's kind of, I look at transplant as kind of a small enough field where we could lay down a path where we're saying, okay, we're going to build systems where we're going to partner with sobriety organizations. We're going to partner with mental health organizations within the Indigenous community and what resources exist to say, this is like a perfect state of what we could create, right? I think it really can be a demonstration for the rest of healthcare if we do it right. But those are great suggestions, and I'm fully supportive of us pushing towards things like legislation, things that actually make it necessary for us to act on these things, because if we don't do it, it's not going to happen. Is my fear. Like, we need to kind of just go out there and say, we're going to make this happen with legislation, and then everyone has to come up to that point. So thank you very much for those comments.
That's great. I see Caroline has her hand raised, so I'll go over to Caroline next.
I'll just add into that. So back in the early 2000s, when there was a lot of attention to fetal alcohol syndrome, we pushed to have pregnant women prioritized for addiction treatment so that they would be bumped to the front of the list. So I have been in touch with Thunderbird Partnership Foundation, Carol Hopkins and her team, and Brenda Verstool and others, trying to ask that question: could we do the same for people who require a liver transplant, that they would be put to so they wouldn't have to have that wait list? So there was a case study of a gentleman who received his diagnosis that he had end-stage liver failure and needed a transplant. It was an 18-month period, and COVID was part of it. But he was doing everything he could. He stopped drinking. He changed his everything so that he could get a liver transplant. And the lack of communication between his primary healthcare provider and the transplant people seemed to have broken down. But he ended up in treatment in month 16, and he died in month 18. And so at that point in time, the question that I had was, would he even have qualified for a liver transplant? Because he must have been incredibly sick. But the idea of him being in residential treatment, which was a requirement, so he couldn't have outpatient treatment, in residential treatment when he was that sick, must have been horrible for him. And so I think, again, what I see talking to patients and to their family members is their communication seems to be one of the big barriers, the big issue, but also an easy win, I should say, or an easier win, because we did have that with pregnant women, that has been a possibility, and it has worked really well to have pregnant women prioritized for treatment, that we could actually propose the same type of idea to addiction treatment people. Often in the case of transplantation and addictions, the addictions people aren't at the table, right? So I would be surprised if there's any addictions people here today, right? So we need to have that cross dialogue, I think, with different people who our patients are interacting with.
Great, thank you for adding on to that, Caroline. I see we have Ramona has her hand raised as well. Did you have a question, Ramona?
Okay. No, I just wanted to share with you that this past May 2023, I lost a daughter to fentanyl overdose. And this is in Southern Alberta, so this was in Lethbridge Hospital. And the doctor asked me if we would consider donating her organs. And, it's a very emotional time for my family, already, with this impending huge loss in our family. But I immediately agreed, And the reason for that was because a year ago, one of my cousins received a lung transplant, and he's still with us today. He performs ceremonies. Took him a while to get back into the sweat lodge, but now he's able to go in, maybe 1 or 2 rounds into a sweat lodge. But with my daughter, I was told that it was mandatory that the doctors ask, that they have to ask the patient or the family, which I thought was good, because I never would have known that if the doctor hadn't have asked me, I never would have even thought to do that. And my daughter had not, she was 30, I think she was 37 years old. She had not filled out an organ donor card or whatever at that point. But I think through this whole process, it's only been a few months, but just recently I got a letter from the recipient who got her lungs. He said he was a husband, a father of 4, grandfather of 7. It was, first of all, it was very emotional for me too. It's a real trippy feeling. On the one hand, I'm very happy for this man, but on the other hand, how he was able to live, it caused, my daughter passed away. But I think that the more I think about this issue, we need to be told more of this. And in our ways, I'm Blackfoot from Southern Alberta. It's not something we really talk about, transplants. It's not even something we've really thought about, to be honest. And so when I received that letter, actually just like last week, I read it. It was very beautiful. And it was part of my healing too, knowing how tragically I lost my daughter, but still she was able to bless another family's life, right? With life. And so then the other things that happened was we donated her, 2 people got her kidney, another person got her liver, and we donated her pancreas for diabetes research. And that was really important because of the prevalence of diabetes in our Indigenous communities, and particularly in my family. In fact, I've got another daughter. I'm just heading to the hospital. She's in ICU. She's just coming out of DKA. So it's really kind of a tough one for us to deal with. But I think on my end, as a mother, as a person from the Indigenous community, the more you reach out to us and explain to us, then we have a better understanding. And when I remember asking a very important question I thought it was really important, to the doctor just before they were going to do to take my daughter's organs. I said, do her organs have to go to another Indigenous person? And that doctor said, no. It can go to anybody as long as they have her the same blood type or tissues. And I remember my first thought was, well, how come there's so much racism? So my next thought was, if a white person says something racist to me, I'm going to tell him, hey, don't be racist. You might be needing my organs one day. But I think for me, it was very healing. It's a really hard thing to have. It's a hard time to have that discussion with families, but it's really important that people just reach out and take those risks. Now, I don't know how many times this doctor has asked families, but he certainly had a good outcome with mine. So I thought I'd share that with you.
Yeah, my second Grand Chief there raising your hands to you. Very powerful story, and thank you for sharing that with our group here today. Had me holding back a couple tears and just express my condolences, and the gift and the strength it takes to move through those emotions and make those decisions is pretty profound. And so grateful for you sharing that experience with us, because it's not an easy one to share. I do recall having a relative as well who was in they didn't think he was going to make it, and so they did have that conversation with the family as well, but he did eventually come out of his coma as well, and is still alive. But I do remember the family kind of having those conversation, and it's a pretty heavy conversation to have. And so, just wish continued strength to your family as well as you all move forward.
Thank you. And I just wanted to mention one last thing. This Friday on March the 1st, the organ donor people, I don't even know what the organization is called, with Alberta Health Services have reached out to me, and they wanted to do a video recording of my sharing my story my daughter's story, so that others can hear that. So I'm very open to sharing that, but keeping in mind that I also have to, I'm open, but I also have to respect her children's wishes, my other children, the siblings. So I'm always really careful about that line, but definitely they are reaching out now, and I'm not sure how many people are willing to share their story, like Grand Chief Stewart there. I'm just really, I think that the more of us who speak out, the better.
Totally agree with you. There's some nice comments as well in the chat too, so I think many of them directed to you and your family. I see Philip has a hand raised as well. Maybe I'll go over to you, Philip.
I just wanted to ask, if I may, what did they do right to address you right, to treat you right at that time? Because I'm in those family meetings and I'm always trying to be sensitive, and I just wanted to know if you were willing to tell me what they did right and how it helped you.
I think it was, obviously, it gets sadder when I share this, but this is my third child I've lost. I had lost 6 months prior to that my granddaughter to fentanyl overdose, and the year before, my oldest son. So this is like huge in my family. But I think it was what helped me, I guess, was first of all, I was shocked to be asked that question while I could still see the monitors. The seeing her, she was still breathing, albeit it was with the breathing tube, and the heart monitors were still up. So in my mind, she's still alive. But I also knew that we were going to eventually have to make that decision to, take off the life support, because I had already gone through these other losses before. But I think it was just having a doctor who was really, really gentle, very caring, and took the time to just sit with me. Sat down on a chair, in the same room where my daughter was. My other son was sitting beside me, and just gently asked me, and he made it clear. He says, "You don't have to say yes, but I am required to ask." And my decision was, remember I said my relative had just had a lung transplant, so that also helped me to, how could I say no when my older brother is still alive, because someone else, gave him that, the lungs to live. So I think it was just a real gentle approach, the gentle nature of the staff there. And, I think even the nurses, everybody there, it wasn't just going to be another addict or another hopeless case or another, it wasn't any of that. It was no judgments. It was more having the whole Lethbridge Regional Hospital, the ICU unit, just having those people who are very caring. I didn't feel any judgments. I felt like they genuinely had a lot of empathy for what my family was being faced with.
That's great. Thank you for sharing that experience too. I know that's a good question, I guess, for people to understand, both sides of that discussion and conversation that can be very, very difficult to have and to hear and to be a part of. So thank you again for sharing this experience. It's definitely something you don't think about, I guess, until it happens. And really appreciate your willingness to come in and share it with us. there's any other questions in the comments here. And a number of thanks to you, Ramona, your family, for sharing that. Maybe what I can do is I did have some other questions that I had as well, and it might be relevant, I think, for the three presenters as well. So it was originally directed to Jag, but I think you've all kind of touched on it as well. As just to switch gears, can you comment on the need for more data on Indigenous patients in organ donation and transplantation? I don't know which one of you would like to jump in first.
Doesn't matter. I can start, and then
Sure.
I think Cindy and Carolyn, I'm sure, have important insights on this. I think I'll provide it from the perspective of someone who is trying to understand the issue as a researcher, for instance. And so the message we've heard time and time again from community and from patients is that we want more data. There needs to be an understanding of where things are going, but that data needs to be interpreted and that data needs to be presented by Indigenous bodies and by individuals that have the right framework of how to present that information. That's where we need to get to. We've come from a place where data was presented, but there was no involvement of Indigenous partners in that. We're now in a place where you can access the data without that involvement of Indigenous partners, which is appropriate. But we're having a tough time engaging Indigenous health partners to actually get that data and look at it in a meaningful way. So that's where I think we need to get towards. We need to get towards making sure the data is collected, but also making sure that we have a way to look at the data we have and track it in the appropriate manner. And so I think it goes back to what Carolyn was saying earlier about making sure that when we look at Indigenous health leaders, that this issue is high enough on the pecking order of priorities that we can capture their interest to kind of look at these issues. And Carolyn, maybe I'll have you take it from there.
Yeah, I mean, unfortunately, if you don't count it, it's like it doesn't exist, right? So that's one of the challenges when I talk to our First Nations and Métis health leaders in Saskatchewan, for instance, the data isn't there, and so in order to make arguments, they do need data, but maybe I'll push this over to Chief Phillip and ask the question of Chief Phillip is how can we mobilize our Indigenous leadership, do you think, across the country? And I know you and I had a brief conversation about a resolution, for instance, passing resolutions to make organ donation and transplantation a priority for First Nations, for instance, as a health issue. So can you give us insight into how, with such busy leadership that have multiple demands on them, how do we push this forward in a way that receives greater attention?
That's a good question. The operative word there is mobilize. It strikes me that we do need a resolution, and we need to have it endorsed by the Assembly of First Nations nationally, our regional organizations across the country, health organizations. I think that that will certainly go a distance to elevate the profile of transplants. I've never ever heard it discussed on the floor of AFN meetings or on the president. I've been the president for 26 years. Our member communities are well aware of my situation, but because of that, I'm not sure what it is. it's the quiet nature of Indigenous peoples not wanting to, come forward. And as I indicated earlier, it's one of the hardest things I ever did was go public and make that appeal. So in British Columbia, we have the Health Authority. And I know that they would be willing to embrace some type of all-encompassing resolution. So all of our quarterly meetings have pretty much taken place. The next target date is June. Then, of course, we have the Special Chiefs Assembly in the fall. Actually, it's December in Ottawa. We're going to have to target one of those, and we're going to have to recruit. I'll talk to our regional chief, Terry TG, and anybody else on the call should talk to their premier if you're in Manitoba. I'm sure that Bob would get behind it. I think that's an excellent idea. So I'll get on this as soon as we end this call. But that's I like that because it's it's the doing instead of being. So thank you very much for that. You made my day.
Awesome. Yeah, that's part of mobilizing the work, and it looks like we're starting to make that happen through this cafe here with just our conversation after the presentations. So that's promising to hear. Just looking at some questions. If anybody else here has any other questions too, open to hearing. I think we have about another 10 or 15 minutes left for discussion before we wrap up. But
So I'll add something in which I think around the data, and that's data sovereignty. So one of the challenges around health utilization data, so for instance, if we are tracking First Nations, Métis, and Inuit identity, and there is data that's produced from that, one of the things that I think in terms of the National Collaborative, and I know, Cindy, we've talked about this in meetings, is what does First Nations, Métis, and Inuit data sovereignty mean in that context, right? So, and again, back to David Dennis, what he taught, I believe, the transplant world is that you can tell a story in very different ways, right? So you can begin by the person who is, and the person's behavior who's struggling with alcohol and can't stop drinking, even though they need a transplant. But you can also tell the same story that began with colonization, and that the responsibility then does not just simply lie with the individual, but it lies with society as a whole, and including making pathways for people to get the treatment that they need and the supports that they need to be healthy. So data is like that, where you can tell different stories. And one of the reasons that First Nations, Métis, and Inuit want and require, and it's a right to have sovereignty over data, is because it's really important to be able to give the right narrative, to give the narrative that is meaningful for the people who have lived experience in that. So I think that's just a footnote to the conversation around data, that no matter what happens in terms of data, we need more data, but we also need to be incredibly respectful around not only the sovereignty of the individual. So each person who tells their story has that sovereignty over their own life history, right? That doesn't belong to anybody but that person. But as it moves up into aggregated data of population data, then we do need to think about how sovereignty is respected and maintained.
Oh, that's really great. Did you have a response to that, Jag, as well, or?
I think Patricia had her hand first, so maybe I'll let Patricia speak and then I can
Well,
follow.
I have
That's great.
related question. So if you want to
Okay.
address
Yeah, so I was just gonna, I think, just in response to what Carolyn's saying, I couldn't agree more. I think the challenge is that I'm concerned that if we're not proactive about even taking, like, there's two pieces. There's getting new data in, which is a longer term piece, but even the existing data that exists right now, refining it, looking at it, and messaging it. And so we understand what current state is. As I showed in my presentation, the last time anyone did that was 10 years ago. I actually don't know what the current situation is in terms of access to care or outcomes or any of those things. And I do think that one of the things, Carolyn, we could do through this body, through the work that you're doing, is to champion that and I think, be the group that's pushing it to say, let's get the right people in the room together, make sure we respect the data sovereignty pieces and still move forward, because we don't want to be a group of, no one wants to be the group that says we're coming in and just getting an approval to get access to data and then run off with the data. That's not the way we want to do it. But I think that I think you could form a really good leadership here, group of people who can do this the right way. But I do feel it's an urgent need, because it's hard to know where we're going if we don't even know where we are right now.
Great point to add to that, Dr. Gill. Patricia, I'll move over to you there to ask a question.
Yes, thank you. My question is for Cindy. So Cindy, you presented the governance of the new proposal for governance for the ODT system, and highlighted the challenges in Indigenous consultation as a part of that. I wondered if you could elaborate a little bit more on some of the comments that you made, a potential connection to the think tank that Carolyn is proposing, or other mechanisms of improving Indigenous engagement in that governance.
Sure. Thanks, Patricia, for the question. I'm the kind of person that's not an either or. It's like all of these things can happen and work together. So I think there's a menu of possibilities that we could do some or all of them. In the new governance structure has not been formally approved yet by deputy ministers. So just a word of caution there. But everything is looking hopeful that that'll be formalized in the early spring. And so the way the structure is set up is that it's assistant deputy ministers who would be reporting into deputy ministers. They would be supported by a patient advisory committee that could include, I would expect it should include, Indigenous patients and family members. And there's also a stakeholder advisory group that I mentioned, made up of clinicians, researchers, experts in the field, that should also include Indigenous representation. And then those groups are supported by a number of working groups. And right now, in our current structure, we have working groups around data, interprovincial working, organ sharing, deceased donation, living donation, research. Going forward, it will be up to the new governance structure to decide, but we are proposing that there be an Indigenous working group, and the idea is that there be Indigenous representation throughout, but also a space for Indigenous people to come together and have their own safe space to talk and hammer out issues. But then, as I've been chatting with Carolyn and listening to her today and her idea of a think tank, I'm also mindful of the capacity that we all have. This is a challenge in the organ donation sector. It's, the same 12 people that are tapped to provide leadership on different issues. So it was just a thought that, if the think tank takes shape, that might be something that serves as a vehicle, or it might be something else. I'm kind of open to suggestion on that. But I think, we need a combination of something that's dedicated for and by Indigenous people, and also inclusive in terms of Indigenous representation throughout all of the entire structure. I hope that answers the question.
Yeah, I saw some head nodding, so I think that that was the answer for the question. So for the next steps in the project that you discussed, I did have another question that was, I think for all of you. It's a question about connection and staying connected. So their final question was, how do we stay connected to the issue and specifically the leaders who presented today? So I think that is the three of you who presented, but also to Grand Chief Stuart Phillip and to Celia DeChambeau as well. So maybe I'll leave that for each of you. Maybe I could pass it to Caroline first on how to stay connected to the issue and to each of you.
Yeah, so we plan to have more webinars moving forward. This was our first try at doing something like this, and so we will have ongoing webinars going forward. We also, just to remind people, we have a second, and I'll get Craig to fill you in with our Maori. So we Maori and our First Peoples of Australia are presenting in a couple hours. We have an international group that meets every couple months. And what we're trying to do is to share between countries that have similar issues. And so geography is definitely an issue that we share with Australia and the folks that are up in Darwin. So while we have cold weather and winter roads and things like that, they have enormous amounts of heat and other kinds of issues that come up, and certainly patient access. So we're continuing to network with them, and again, we will have webinars that will include our international colleagues. We don't have anything formal. We did have the First Nations and Métis, Saskatchewan First Nations and Métis Organ Donation and Transplantation Network. And now with the relationship with the Canadian Donation and Transplantation Research Network program, that we hope to, and maybe Manuel, I don't know if he's on, but we've talked about having a listserv, a way in which people can keep connected to this group, and we can build so that we do have a way to share information and to get information out. If anyone has any ideas on how you feel that we could improve that, please let us know. Yeah.
Caroline, I'll quickly jump in here. This is Manuel here. Yeah, we do have everybody's contact for registering for this event, so we will definitely keep everybody posted on the activities that we have coming up. We've referenced the CDTRP Indigenous platform a couple times over the cafe, and if you go to our website, cdtrp.ca, you won't see it live. We're just currently finalizing the final stages, but all the information regarding this cafe and future activities will be there. So stay tuned to your emails, and you'll get an update very shortly.
Awesome. Thanks for that, Manuel. Jag, how could people stay connected to your work with the bridge?
I'm happy for Manuel when he sends that information out to include my contact information. I think that's an individual decision for each person depending on their bandwidth, but I'm happy to share mine. So if people want to get a hold of me, they can.
Awesome. And Cindy, how can people stay connected to you and the work that you're doing? You're muted, Cindy.
Sorry about that. Yeah, feel free to share my contact info, and I'll continue to work with Carolyn and Jag and others. So, I mean, people might need some time to reflect on this in terms of what comes out of this meeting, but maybe there'll be a little core group or something that are interested in kind of leading the next phase. And if it's helpful for me to be a part of that, I'm happy to be a part of those conversations and discussions. And for anyone sort of kind of looking to how they can how they can participate in this new governance structure we're setting up. Would really love to have some conversations with people around that. So you can do it through me directly, Carolyn, bit of a working group. I don't know. We'll see. I don't know if hundreds of people are going to be storming to put up their hands, but if there's a few people interested, maybe we could have a little task group or something, if that makes sense.
Awesome. That sounds great. And Chief Philip, I see your hand up as well. How can people stay connected?
Yes, for myself, I've had some engagement with Bridges, but this is the first time I've been in this forum, so to speak, and I'm really grateful for the dialogue. In terms of moving camp, I think we have to be, a little more organized than we are at the moment. And just reference a notion of a resolution, that work can start from the medical side, so to speak, in terms of what the need is. But we have to be strategic in how we ripple out. Otherwise, it's just going to be a mass confusion and whatnot. So, but I don't know if it's possible or not, but it sure be nice to see everybody in person in the same ballroom, and maybe a little food and some coffee and whatnot would be nice. So I don't know if that's possible, if we have the money or whatever, but I certainly would be available. I've been known to drive from my home in Penticton to Yellowknife and to Ottawa and Montreal, and so I'm up to going anywhere that we need to get together and spend a couple of days. Right, Lim.
That's great. I agree. It's always good to have feast to bring us together.
And that's definitely something that we've been talking about and working towards, finding resources. The ideal context, I think, would be a consensus development conference that is Indigenous driven, and we have a model for that. And so we will definitely be looking for resources to have an in-person meeting and to bring people together. And there's a number of ways we can do that. We can do it on a smaller scale, attached, JAG, for instance, with the Canadian Society for Transplantation's meeting, and have a pre-conference gathering, right? So that would be a companion to that conference, or we can have something that is standalone.
Yeah, I fully supportive of that, Carolyn. We can make that work. I also think in the interim, while you're working towards that, I'd be keen to get a small group of interested individuals together, and we can look at, like, we can find funding somehow, like amongst us, just to get even a small group together from a planning stages standpoint. And Chief Philip, we could easily make that work to, depending on where we're doing it. We if it works, we can do it in BC or Alberta, not make you drive too far. So we'll try to make that work.
Oh, that's great. Yeah, sounds like there's some wheels that are starting to turn, and some wheels that will hit the ground and be put in motion. So I think that kind of concludes our Q&A portion. So I know we have about 15 minutes for some closing comments, but I think one thing I wanted to do, I know we've been sitting for a while, so if you're sitting at your desk, I want you to lift your arms up, give them a good stretch. I could see you, Jag and Caroline and Stuart, Grand Chief Stuart. Give your neck a little roll. as best you can, move your arms. If you can't move your arms, move your eyes, move your neck a little bit as much as you can. One thing I always like to do when we have these conversations is move a little bit. And something I did at a recent panel discussion that I was part of is I asked people to open their hands, and when you're reaching up, think of, those that have come before us, and those that are with us now, and those that have yet to come and be with us. Think of them and just remember them in all of the discussions that we've had today, and bring that feeling and just rub that spirit on you. And just to go into our closing, just to remember, all of our ancestors that have come and those that have yet to come are a part of this work and a part of this journey that we're all embarking on. And also to those of our kin and relatives who have talked about their families as well that have been affected too, just thinking of them. And so I just wanted to do that before we go into some closing comments, just to move some energy around a little bit. So I know that there is a survey link that is going to be posted as well into the chat, just to get your feedback on the session today. And so I'll hopefully that you'll have some time to fill that out. And as Caroline had alluded, there is a second session that is upcoming in just over 2 hours from now. So whatever time zone you're in, about 2 hours and 12 minutes from now, we'll be having the international session with some of our relatives and kin from Australia and New Zealand. And so I'll be looking forward to hearing from them and the journeys that they're on, and how they intersect and align with some of the journeys that we are embarking on here in what we now call Canada. And so, looking forward to hearing from them as well. And hopefully you'll be able to join us there as well. And so I'll share that to kind of end off, but I'd also like to pass it back over to Caroline for closing comments from her, and if there's anybody else that you'd like to pass on for closing comments. So Caroline, over to you.
Yeah, so so thanks so much. I had butterflies this morning. I was very nervous when I woke up this morning about how this was going to go, and the technology was the big thing. And I just want to thank everybody for being here. You'll laugh. I live in northern Saskatchewan, and our colleagues, our Maori colleagues, and First Peoples colleagues from Australia, I keep threatening to bring them to northern Saskatchewan in February, and and put them on cross country skis, and we have dog sleds and snowshoeing and ice fishing and all kinds of snowmobiling, all kinds of, it's really fun up there in the wintertime. And so I keep threatening that that's when I'm going to bring them to come and visit. So, but I do hope that we, if we do have some kind of a forum in person, that we find a way to bring some of our colleagues, because, and I really encourage people to join the next session, because I get a sense from our meetings that they have thought through some of this more than what we've been able to here in Canada. So I think it'll be really interesting, and they're just wonderful, lovely people who are just, as as I said, like Terry, they show up every day for their people, right? And you can tell that the commitment is so strong, and so we've had a very wonderful partnership with them. I don't know if Terry is still on. I know that she had joined us by telephone, so I don't know. Terry, are you still there? Yeah, I think she probably had to go on. So I'll just close it off by just saying thank you so much for this. This will be the beginning, I hope, of lots more to come, and we will keep you through the CDTRP website, and the Indigenous platform will keep you informed. And I just want to thank all the speakers. Oh, I think Terry's there now.
Yes, I'm on, Caroline.
And I just want to thank all the speakers for taking the time to join us, and just remarkable. It's very humbling, and just for your generosity and that. And I will turn it over to my very good friend who's up in northern Saskatchewan, probably in a snowstorm today. Hey, Terry.
No, it's not really that bad. Oh my goodness, thank you so much for bringing me here. It was just incredible day. I ugly cried, but not as bad as Craig. No, I'm just kidding. I don't even know you. It was such incredible stories from Celia and the Chief Philip. Oh my gosh, I just cried because this is so important about, like, even with me battling with my cancer. That's why I do what I do, because I strongly believe we have to educate our people. We have to tell them our journeys. That's how we learn. And it's so powerful, the stories you told today. I just was so happy and so sad at the same time. And igwisagi hitu e o mat ai sinwak tap topu go tamamao tasagi hitu e tau itiwaga nihitu ya. It's so important to share the love that we have. And you know, like even with when he talked about the people at his treatment, that's how it was for me with Saskatchewan Cancer Agency. They're just like my family. They just treated me so good. And to this day, you know, anything I need, they'll call me or I'll call them. And tapipo go tap mamtoni tamaho masagi hitono tani sa toskia mina ego ange kagot ni tekoge leadership go pogan matasitos kawaya ko tap tau apito gusana kwange ay skituino ag poguta sohki ma ko man towi togo tegi pakngutik. That's all I have. Thank you, Caroline. Thank you everyone for taking your time out today.
Thanks, Terry. And and I hope to see people in a couple hours. And thanks for attending, Craig. I'll turn it over to you.
Okay, I will say Sani, Nigo Wagmak. Thank you, my relatives. And I'm sure, Elder Terry, you did not ugly cry as bad as me. So, and I just want to mention, so Celia Deschambault, Grand Chief Stuart Phillip, Elder Terry Gardner, Dr. Jag Gill, Dr. Caroline Tate, Cindy Moriarty. Just want to announce everybody's name once more before we end our session and say thank you to all of you for taking the time to come and share your knowledge and experience and expertise with us today. And thank you to everybody who came to this session as well and asked some very good questions for us to all to think on and to answer and to hear some more information on the work that's being done in this field. And very close to home. And so also to people who shared their emails in the chat, I saw that as well. And so I'm sure that the organizers here will make note as well and share more information. And I saw, Samantha, that you're one of the new navigators. So that's promising and good to hear that. And maybe I'll see you in St. Paul's Hospital one of these days when I'm at an appointment.
Yeah, I'd love that.
I'll have to reach out to the wellness team.
Mm-hmm, for sure. Thanks.
Awesome. And so with that, I'll say miigwech, and I wasn't planning to, but just give me 1 second. Oh. So I have it hanging with some medicines, but I was just gonna sing 2 push-ups to end us off. And this is my little baby rattle. You see my little. So I was gonna sing something. Okay, sheko mane tu homekwina ne takare. Waya hare, ya hare, ya hare. Waya hare, waya hare. Waya, heya, 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 Shiku Manetu Omikwana Nitakare Wayo Hare Wayo Hare Wayo Hare Wayo Hare Wayo Hare Wayo Hayo. Oh, Egosani, miigwech everybody for coming today, and I just wanted to share a song with you to send you all off and back to your home fires and the rest of your work days. So hopefully we'll see you in a couple hours, and take care. We'll see you again.
Thanks, Craig.